Hi everyone, welcome to Dr. Deepa's Learning Launch. I'm Dr. Deepa. I hope you enjoyed all my videos till now. And as a part of the New Year celebration, I have already put in the social media that I will be taking lessons for a batch of 10 according to their customized schedule. Anyway, this is not a part of that schedule. And now today we will be discussing about RBC inclusions, which is very important. It's a very common finding to see RBC inclusion, but sometimes these go unnoticed in the routine heavy load of work that most pathologists have. So without much ado, let's look at the images and look at the slides. So primarily, when you're looking at RBC inclusions, you need to also understand that knowing about RBC inclusions is also very much of a diagnostic importance because you will be missing a lot of diagnosis in case you do not understand the difference between, let's say, Heinz body, Pappenheimer body, or any case scenario in which do you need to do a supravital stain. So these are things that you have to know. So let's go on. So the first is the RBC inclusions that we have are basically the nuclear remnants. There are nuclear remnants which we have, which are Howell jolly bodies, Cabot rings, cytoplasmic granules like basophilic stippling and Pappenheimer bodies, and siderotic granules. You also have hemoglobin precipitates like Heinz bodies, alpha beta chain inclusions, crystals and other inclusions like those in porphyrias and actin inclusions. You can also have microorganisms which will mimic these. So beyond the size and the shape of the RBC, the inclusions are a powerful diagnostic clue because they are usually the iron containing aggregates or precipitated hemoglobin or pathogen, and recognizing these and distinguishing these inclusions will lead to diagnosis of, let's say, a hyposplenism, a lead poisoning, sideroblastic anemia, unstable hemoglobin disease, or if it is actually a parasite and not an inclusion. So these are things that you have to be competent in differentiating. So first, let's talk about the Howell-Jolly body and the basophilic stippling. The Howell-Jolly bodies are classic markers of hyposplenism. So they are the surgical post-splenectomy type of an inclusion which you see, or it can occur in functional diseases where there's autosplenectomy, like in sickle cell diseases, and where there is extensive splenic infiltration. So they are also very much frequent when erythropoiesis is abnormal or high, especially in cases of megaloblastic anemias as well. So Howell-Jolly bodies, I will show you the image. The next that we talk about is basophilic stippling, which represents the ribosomal RNA and other aggregates that is seen in a wide spectrum of disorders of disturbed maturation. Coarse stippling plus anemia should make you think of lead poisoning because of pyrimidine 5' nucleotidase deficiency. So that is one thing you have to keep in mind when you're looking at a basophilic stippling. So if you can see in this image on the left, what you're able to see are these small pimple-like dots on the top of an RBC. So they look like they're stuck on appearance. So this on the left is a blood film of a patient who had splenectomy after an autoimmune thrombocytopenic purpura or ITP, showing one Howell-Jolly body. So what you're able to see here on the left, like a small dot or a pimple on the RBC, this is what is a Howell-Jolly body. And there, you can also see some acanthocytes here and there in this peripheral blood film. On the right, what you're able to see is a blood film of lead poisoning, and you're able to see some polychromatophils here. That's a neutrophil, and this is basophilic stippling. There is coarse granules all over the RBC, unlike just a single dot in the Howell-Jolly body. So this is something you should be aware of. And this is the third image. This is the third image of a patient having COVID-19 infection. So here also you're able to see these dot-like areas of basophilic stippling, but this is not as prominent as this previous image. But yes, you do see these basophilic stipplings in these RBCs here as well. Then we should next discuss about the Pappenheimer bodies. The Pappenheimer bodies are iron-containing granules that are confirmed by the Pearl stain. So basically, after splenectomy, a small number of Pappenheimer bodies are pretty normal. You don't have to worry about it. But heavy Pappenheimer load is seen in sideroblastic anemia and in severe iron metabolism disturbances. So if there are one or two during a recovery from a splenectomy, then it's okay. You can ignore it. But if there are many Pappenheimer bodies, then you have to raise a concern of sideroblastic anemia, but it is good to report even if you have less than 1% or whatever is the percentage according to the number of RBCs. I usually prefer reporting it as percentage RBCs, so that is how I report it in my reports. Then the next one we have to discuss is the Heinz body, which is a classic of oxidant hemolysis. So alpha beta chain inclusions act similarly. So these are seen in severe thalassemic states, and the inclusions trigger somewhat like a macrophage pitting, leading to an irregularly contracted cell also. And there can be a bite cell whenever you're seeing these Heinz body as well. So this is a blood film of a patient with sickle cell anemia. You're able to see this sickle, not fully formed sickle, but yes, there is this. You still call this a sickle cell. So these are the abnormal sickle cells here, and along with that, you're able to see these Pappenheimer bodies. Pappenheimer bodies, you have to be you can see that they are peripherally located. The central pallor is clear. These dots are peripherally located, and there's some tendency to cluster together as well. So these dots that are seen in the periphery and have a tendency to cluster together, so that is a classic picture of a Pappenheimer body. So that's how you differentiate with the other inclusions that we just discussed. Then the next inclusion we will talk about is the Cabot ring. And the Cabot ring is a rare and intriguing type of inclusion body. I have, I think, seen two or three in my practice. That's it, and not many. But these represents deranged mitotic figures. So these are deranged mitosis. So you see them in severe dyserythropoiesis and in megaloblastic anemia, and sometimes in microtubule deficiencies or disrupting microtubule disruptions after chemotherapy. And porphyrias and rare genetic syndromes also can produce these type of bodies, and there are other rare inclusions also that you can see in these for example, the presence of crystals in congenital erythropoietic porphyria. Always in the decision of reporting a particular inclusion body should be done only with a clinico-pathological correlation, especially if you're thinking of any porphyrias which can cause abnormal crystals in the RBC. Then it is good to integrate with the clinical findings and pick up the phone and call the clinician and ask if there is any symptoms or signs of porphyria before you report these. Okay, so here, this is what I was talking about. So on the left, what you're able to see here is the Cabot ring. This is a figure of 8 Cabot ring here, and you have a sort of roundish Cabot ring here. Do not confuse this with any parasite. So this is a Cabot ring. And on the right, you're able to see this crystal-like inclusions that are usually seen in porphyrias. Then another very common inclusion that you see, per se not an inclusion, but a precursor of the RBC, which is nucleated RBC, but still put in the books as inclusion. But nucleated RBC is, once you see a nucleated RBC beyond the neonatal period, it is still a red flag. So in the adult, it is definitely abnormal. So NRBCs can reflect a strong marrow drive to push the immature RBCs right out of the marrow and not giving it enough time to mature and become anuclear. So that is what happens in presence of NRBC. So it definitely represents a strong marrow drive, and it also can represent hemolysis or hypoxia or a marrow disruption or a marrow infiltration or in the preliminary fibrosis, that is prefibrotic stage of primary myelofibrosis. So any of these disorders, you can see NRBCs in the blood circulation. So when you see both NRBCs and immature myeloid cells, describe that as leukoerythroblastic picture. You can't call it an NRBC scene. And as you know, the NRBCs are reported as number of NRBCs per 100 WBC. So that is how you report it out in your report. So in neonates, there are higher NRBC counts because of prematurity, because of hemolytic disease of the newborn, and because of hydrops fetalis or hypoxic stress. So any of these also can cause increased NRBC. So you look at the reference ranges in your laboratory for the NRBCs in a child versus an adult. NRBCs in a child which is a neonate is still higher. But when you see it in a very, very high range compared to their age reference, then you have to think of some hypoxic change that is happening in the baby. That also has to be reported. So in an adult and especially in intensive care population, you do see NRBCs, which is an independent marker of a poor outcome as well. But in post-chemo patients or in people where you have given any hormones to expedite the marrow function, in those, then expecting NRBC is a good sign. But otherwise, it is something that you have to report and inform the clinician. So this, you are able to see multiple NRBCs here. So these look like, these are the pinkish cytoplasmic cytoplasm of the RBC. And it has this nuclei, which is not gone yet. So this is a mature RBC, and these are the NRBCs. So this is a blood film of the baby with actually diagnosed sickle cell anemia. So few of the NRBCs you see is in the last stages of mitosis. So there are some different looks of the NRBCs in this. So the film is also showing some anisocytosis. See, you see polychromatophils here, you see polychromatophil here, you see larger and smaller RBCs here. So there is some dyserythropoiesis for sure. So the uncommon feature in circulating NRBC is that you have these different stages of NRBC. You usually don't see them. Usually you see just this type of an NRBC in your peripheral smear in an adult population. Then there are some other changes in the RBCs which I wanted to include in this, so that just for the completion sake, because these are also important to know. So there are some things that you have to know. One is agglutination versus rouleaux versus rosetting. So these are some of the terminologies that you have to be aware of. So agglutination is different from a rouleaux. And agglutination is an irregular antibody-mediated clumping, which is more like a clump, a set of 10 RBCs that come together, which is seen in cold agglutinin disease and paroxysmal cold hemoglobinuria. Rouleaux is more like an orderly coin-like stacking of the RBCs. So this orderly stacking occurs in fibrinogen or immunoglobulins when they are high, then that is the reason why you see a rouleaux formation, which is classic of myeloma or heavy inflammatory states. So the RBC rosetting is something that happens when the RBCs cluster around the neutrophil. That is also something that you might see. It is not an artifact per se. So when the RBC is rosetting around the neutrophils, it's pretty rare, but it is very striking because your entire peripheral smear, just like you see platelet clustering around the cells, around the RBC EDTA artifact, similarly, sometimes you do see RBCs clustering around the neutrophils and the entire smear will be filled with those cells. So this red cell rosetting around the neutrophils is rare, but it might indicate an immune-mediated event, and sometimes it can be EDTA dependent also. So when you have this kind of clustering and you have a repeat sample taken, let's say in heparin, and you still see this clustering, then it is more immune mediated. So when you have immune mediated thing, you have to suggest to the clinician that there can be there is likely autoimmune hemolytic anemia process which hasn't occurred yet, or there is a likelihood that the patient is experiencing this, and you have to pick up the call and talk to the clinician and inform that you are seeing RBC rosetting and that the patient needs to be investigated in these lines. So I hope you like my video so far. So to summarize, the red cell morphology is a rich source of diagnostic information, which you all should be aware. You agree so far. So by systematically accessing and looking at the size, the hemoglobination, the shape, the inclusions, the cell-to-cell interaction, like in cases of rouleaux clustering or agglutination and rosetting, all of these are powerful clues for an underlying disease. So these findings must always be correlated without fail with the patient's age, physiological state, any automated indices, if they are available, those they need to be correlated. And although the modern analyzers provide some parameters like clustering or clumping as a flagging, but it is always mandatory that you look at the peripheral smear before you and report these inclusions and these RBC abnormalities, and always do a clinico-pathological correlation. So thank you for listening to me today. So this is about RBC inclusions and abnormal stacking. So I hope you like my video. Stay tuned to Dr. Deepa's Learning Launch for many more such videos. Bye-bye.